We're very glad to have Dr. Amy Rosenberg here with us today. Dr. Rosenberg is an ID specialist, and as you guys know, she also holds administrative position. She's a vice chair for medicine, and also leads the QI project type of thing here in our institutions. So she's the point person if you want to do a QI project. She's the go-to person for that. So we're very happy to have you here, Dr. Rosenberg. Thank you for accepting to take the challenge. All right.
Happy to be here.
Okay, so we're going to start our case. I have to say, I don't think this is a particularly difficult case, but it has a lot of very important teaching points for all of us because it's something that we encounter very frequently as residents. And pretty much many of the questions that I'm going to ask you today are questions that I found myself having when I was taking care of these patients. So let's start with the case. So this is a 57-year-old male who has a past medical history of diabetes. He's also a cigarette smoker, has a history of alcohol abuse and IV heroin abuse. So he presents to the emergency room with malaise and fever for the past 5 to 7 days. So he describes a generalized malaise and fever at random hours of the day. He has been taking Tylenol for fevers, and he had last used heroin about 4 days ago intravenously. In the ER, his vitals were blood pressure 105/70, his heart rate was 78, his respiratory rate was 18, his temperature was 100.8 Fahrenheit, his BMI was 20. On physical exam, he looked disheveled and sick. He had trap marks in the arms bilaterally. His neck was supple, lungs were clear to auscultation, heart sounds were normal, abdomen was benign, the extremities did not show any edema or any other abnormalities, and the skin exam wasn't remarkable otherwise. The only positive finding on the skin was the trap marks. So the team taking care of this patient initially sent CBC, a BMP, hepatic function panel, and they obtained blood cultures. So my first question to you, Dr. Rosenberg, is particularly in regards to the blood cultures. So can you explain what is the correct technique to obtain blood cultures and how many blood cultures should be obtained in a patient like ours? And how about timing of obtaining blood cultures? Should they be obtained while the patient is febrile?
Okay, so first of all, in terms when you have a procedure that you have to do, and this is in fact is that better? This is in fact a procedure, even though it's it's not an invasive procedure, it's still a procedure. So when you think about it, you have to know what is your indication for drawing blood cultures. So unfortunately, as doctors, we're not good at predicting who's going to be bacteremic. So if you look at data from all over the world, and actually our own data shows that only like about around the world, it's like, let's say about 10%, and here it's like a little bit less than 10% of patients who we draw blood cultures from will actually have positive blood cultures. And those can include contaminants as well. So, people have said, okay, so let's come up with scoring systems to determine who we should draw blood cultures from. And those haven't been very successful either. There have been a couple of scoring systems, but in fact, they haven't really proven to be that effective, or if they have, they're just not very practical. So who should we draw blood cultures from? So we know, because we deal with a lot of issues with sepsis, we know obviously that patients who come in with sepsis, we should draw blood cultures from. We should draw blood cultures from anybody that we think has a source of infection that may become bacteremic, so meningitis. Meningitis also is very important because about half of patients will have blood cultures that are positive, and you can make the diagnosis based on blood cultures as well. If a patient has a deep abscess, they might be bacteremic. And also, who else you draw blood cultures on are patients who you think have endocarditis or other infections. So we don't have like a huge, we don't have the greatest indications, but I think people have a general idea of who we should draw blood cultures from. So do you still do the sim lab? with
We do the same
so,
lab,
okay, so basically people have been taught how to do blood cultures, and one of the most important things when you're drawing blood cultures, of course, is your technique. And obviously you have to clean the skin off very carefully and very well using chlorhexidine, which is what we use here. In my day, many years ago, we used povidone iodine, and that's been shown not to be as effective as chlorhexidine. One of the most important things that you need to do, which I'm sure you've all been told, is to make sure that you have at least 10 mLs of blood in each blood culture bottle. And the reason for this is that the concentration of bacteria in the blood in patients who are bacteremic is very low. So you have to make sure you have enough blood to be cultured in order to get the bacteria out. So let's see. So that's very important. And it's also been shown that if you have less than 5 cc's in each blood culture bottle, you're really not going to culture out bacteria. Now, in terms of the timing, so it's not true that you have to be febrile in order to draw blood cultures. So you can draw blood cultures at any time. If there's an indication, you draw them. So you don't wait until the next time they're febrile.
How about the number of blood cultures? How many should we?
Yes, so the number of blood cultures is a little bit less clear. So there are actually guidelines from the ID Society of America and also the American Society of Microbiology, which say you should draw 2 to 4. So that's very clear, right? So the endocarditis guidelines from 2015 say that you should draw 3. Okay, so what's clear is that 1 is not enough. So with 1, you'll only get about 73% of the bacteremias. And also, the issue with 1 set of blood cultures is that if you get what you think might be a contaminant, you don't have the other set to look at to determine whether or not you have that same microorganism in the second set. With 2 blood cultures, you're going to get about 90% of bacteremias. With 3, you're going to get about 96% or so, and with 4, you'll get close to 100% of bacteremias. There was one study which showed that if you do 2 sets of blood cultures, if you take out all the contaminated blood cultures and you take into account the fact that there are sites of infection that you might find that are separate from bacteremia, with 2 blood cultures you only miss about 5%. Of bacteremias. So with that in mind, I would say that we all by convention here do 2 sets of blood cultures. Obviously, the more blood cultures that you get, the more likely you are to get a contaminant. So that's the downside. Also, I think people get quite annoyed with us as the more sticks that they have. And also you have to take into account the time. So, we all know, I think these days with sepsis that, the recommendation is to get those blood cultures within 45 minutes before antibiotics. And if you can't do that, then you give antibiotics. And that's another point, which obviously that we know, which is that with antibiotics, you want to get the blood cultures before antibiotics. I was just telling my team that there was a study that just came out in Clinical Infectious Diseases where they looked at the percentage of patients with positive blood cultures with sepsis, and in this study it was about 30%. And then they gave antibiotics and they drew blood cultures, and it turned out to be about like a half an hour to 4 hours after, and they found that only 19% of patients had positive blood cultures. There were some problems with the study, but it's interesting that these kinds of studies still go on because there isn't a lot of data on what happens when you give antimicrobials. But at any rate, so getting back to your question of the numbers, so I would say you draw 2 sets of cultures because you're going to get most bacteremias. And then you can draw a 3rd culture, which doesn't necessarily have to be at the same time. You might want to go back and, if the patient's still febrile, and do another one within 24 hours, or you might decide just to do 3. Interestingly, Staph Aureus, the percentage bacteremia will vary depending on the organism. So Staph Aureus, with 1 blood culture, about 90% will be cultured out. So that may have to do with this thing of whether the patient has continuous bacteremia or intermittent bacteremia, which there is a theory that that's correct. There's a theory that it isn't correct, and everybody really is persistently bacteremic, but that's sort of a different discussion.
Great. So as much as we train people and we repeat these, I really wanted to ask you this question because we've observed that many people keep on drawing only one blood culture. Sometimes the timing is not necessarily correct. And we keep on seeing this thing on the sign out. If the patient is febrile, only then just draw a blood culture. And there's really no evidence to support that.
Right, right. There's no evidence to support that. I think, maybe what people are thinking when they write that in the sign out is that maybe there's something new going on with the patient. So that would be an indication to draw blood cultures, yeah.
So you mentioned contaminants. So how often do we isolate contaminants? And the follow-up questions to that would be, what are bacteria that are usually considered to be contaminants? And which bacteria are never contaminants or almost never contaminants?
Okay, so contaminants. So I don't know. Is it helpful if I write stuff for you guys too? Okay, so really the number that is quoted is 3%. So we should have less than 3% of our blood cultures should be contaminants, and this is a number that everybody through the country has data on. So our infection control department has a definition whereby they determine what are contaminants. So this is like a surveillance definition. So they don't look in the charts to determine whether or not clinically it looks like a contaminant, but it's just it's a surveillance definition. So your number is supposed to be less than 3%. I'm just going to take a drink for a second. So so what are our numbers, you're wondering? So we pretty much are less than 3%, our contamination rate of our blood cultures. Some months, so they do it by month, and some months are less than 2%. Some months it's like probably like 1 month out of the year it's like 3%, but I think with the training in the sim lab, it's really kept it below 3%. So what are some bacteria that cause, that we think cause contamination? So the coag-negative staph, of course, everybody knows coag-negative staph can be associated with contamination. There's one caveat to that, which is Staph lugdunensis, which is actually one of the more virulent coag-negative staphs, and that may be more likely to cause infection. So if you get that bacteria, you might want to call us and ask us about that, because it is a little bit different. And it acts more like Staph Aureus. So coag-negative staph, so skin organisms, obviously, are most likely to cause contamination. So coag-negative staph, Corynebacteria, which are skin organisms, Bacillus species can cause it. Am I missing anything else? Those are pretty much the ones that are going to cause it. So
the other question is, what are organisms that should never be considered contaminants if you get a positive blood culture with them?
Okay, so what should never be considered is not a contaminant is Pseudomonas and other gram-negative. So if you see that, those are definitely real. Staph Aureus, even though it could be on the skin, and it is on the skin, we have to consider that as real because it's a very virulent organism. Group A strep. Let's see, so other gram-negatives like the Enterobacteriaceae, like Klebsiella, E. coli, and then other organisms that you probably know of, so like Listeria, Meningococcus, bacteria like that. So those are always real. Oh, and besides bacteria, also Candida. When you see that, you have to consider that as real.
Right. So just coming back to the possible contaminants, so how do you interpret a positive blood culture, let's say, for a coag-negative staph, because they can also cause disease. So how do you interpret those results when you have a patient that is sick and then the blood cultures are going coag-negative staph?
Right. So, so that's why it's very important to draw at least 2 sets of blood cultures, because if you have one set of blood cultures that has one of those organisms, the other one is negative, that's less likely to be less likely to be real. So it's more likely to be real if you have multiple blood cultures with these organisms. And also if you have a foreign body in you, so like a cardiac device or any sort of foreign body, then that's more likely to, or a line, especially a tunnel line. And you get one of these coag-negative staphs, for example, those are more likely to be associated with infection.
So now, just coming to the question of foreign bodies. So what about when we have a patient that has an indwelling IV catheter or a central line in the ICU? Should blood cultures be drawn from these catheters? And if so, what are the caveats to interpreting these results?
Okay, so I wish I had a cough drop. So tunneled catheters like Hickman's or ports like porticasts are different from, say, PICC lines or a central line that's put in the ICU. So patients come in with fever who have a Hickman or who have a port. It's very important, first of all, to look to see whether there's a localized infection. So if patients have like a tunnel infection, so they have erythema or and tenderness along the line or at the site of the port, you really have to think about taking out that line right away is the first thing that you do along with giving antibiotics, because you won't cure those. And the patient will just get sick, and especially if they're septic. So don't think just about antibiotics, but think about source control. And especially with a port, there probably will be pus underneath that port when you take it out. That's if you see erythema and tenderness. So in terms of drawing blood cultures, so you have to think, is there another source of fever for this patient who's coming in? So, if the patient has pneumonia, if they come in with cough and a chest x-ray that suggests pneumonia, then you think about that. You don't think a malign infection. But if there is no other source of infection, then you should actually draw blood cultures from the port or from the Hickman and one set of blood cultures peripherally, so you can compare the two and decide whether you think that there's an infection or not. Now, having said that, I'm going to get into a little bit more controversial area, which is, if you're in the ICU and the patient has a line in or a PICC line in, and the ICU is saying, you shouldn't draw blood cultures from the line. So in general, you should not draw blood cultures from a central line, especially because you're going to get contamination, because that with time, the longer the duration that a line is in, the more it's going to be contaminated. So you should, in those cases, draw peripheral blood cultures.
I think aside from that, the policy here in the ICUs is that if you want to draw blood cultures from a line, you need to call the attending and get authorization from them.
Right.
All right. So then on a different line, so let's say we did send blood cultures and it was a correct technique and we considered all of this stuff. So how long does it take for a blood culture to grow an organism?
Right. So these days we have continuously monitored blood culture systems. So what that means is that they're actually very good systems, and you should have a positive result within 48 hours, and probably a lot sooner. So sorry, so I'm getting over this cold and now it's gone into my throat. So, so these days, so definitely within 48 hours, some organisms it takes up to 5 days to get them. So we do hold blood cultures for 5 days because these days we can actually get haystack organisms, which before we used to have to tell the lab, okay, hold the blood cultures because we think we might have culture-negative endocarditis with the haystack organisms. Everybody knows what I'm talking about, right? But now those should come up within 5 days, and also Brucella should come up. So these days, blood culture systems are very good.
So do we have any other different things that we can do in the micro lab with these cultures to get results much faster? I was reading that some people are doing PCR and things of that sort with the cultures, and they can get results in 6 to 8 hours as opposed to 48 hours. Do we have that available in our cultures? No?
Yes. So we don't have PCR, but what happens is, so these blood culture systems, so these blood culture bottles are being continuously monitored. And when they turn positive, what the lab does, and again, I'm not a microbiologist, but what the lab does is they'll do a gram stain. So that's when you get the result that the blood culture has gram-positive cocci on gram stain. So it hasn't grown, but it's on gram stain. what they do is they take the blood and they do this MALDI-TOF on it. And the MALDI-TOF is a mass spectrometry. So what it has a library of numbers that they have, and they match them up with this blood. So that's why you're going to get an identification much earlier than we used to. And it's a preliminary identification until they do the final culture. So you will get a preliminary result of pneumococcus or E. coli, whatever it is, based on the blood itself, not on the culture, which will take a couple of days to get the final culture result with the susceptibilities. But this is really groundbreaking because you do get the result much sooner than we did before.
Absolutely. Does it apply for fungi as well, or is it only for bacteria?
Yes, yes.
Fungi as well. Yeah, I always I think I shared with the residents the other day, we're talking about mycosis, and there was a case that I had when I was an intern that I always remember someone who was immunocompromised, was growing yeast in the blood cultures, and the patient was on caspofungin, and then after 4 or 5 days, it was cryptococemia.
Oh.
The patient actually passed away from that, and I went into the sort of like the reviewing spree of trying to find out if there was a way to figure out that before.
Yeah, so Candida is only going to be found in about 50% of blood cultures, but the systems that we have now are good enough actually to find them. Regular blood culture bottles for Candida.
So in regards to culture media, and this is another question that we get sometimes. So normally we get only the aerobic and anaerobic bottles for most of our patients. Are there any scenarios where we need to culture blood in a different culture media?
So, so as I said, the regular aerobic, anaerobic bottles are very good for culturing out most things. The isolator blood culture, which is a lysocentrifugation technique, so it's a different technique. So you can use this to get some fungi, so some dimorphic fungi like histo, or AFB, so MTB, or more commonly M. will grow out from isolator blood cultures. Like I said, you can actually use just regular blood cultures these days to get Candida. So that's really what we have here available. And isolator blood cultures, it's more labor intensive, so that's why you shouldn't just draw them if you don't really need to draw them.
Right, so let me give you a little bit more of information about our patients. So some of the labs are HemeSend showed a CBC with a hemoglobin of 11.5, and the MCV was 90. WBC were 12.5 with 85% neutrophils. Platelet count was 190,000. The BMP was entirely normal. In terms of hepatic function panel, AST was 85, ALT was 55, ALPHOS and Billy was normal. That's my phone. Sorry. So UA showed 40 RBCs and 2 plus protein, and 3 WBCs. Chest X-ray was normal, and an EKG showed sinus rhythm and a first-degree AV block. So from the perspective of an infectious disease specialist, do these lab results sort of like move you in any direction at this point with this patient?
Okay, so what you're telling me is that he has a little bit of a white count, and thank you for giving me the diff, because we always want to know the diff. So he has 85% poly, so there is most likely something bacterial going on. The anemia, so he has anemia, but he has a normal MCV, so I'm thinking, anemia of chronic disease. He has a lot of chronic diseases, so perhaps that's nothing new. He's got a little bit of transaminitis. He's an alcoholic, so his AST is elevated. So in the UA, he has 40 red cells. So when someone like this, I'm thinking, okay, maybe he's got, maybe he has a little bit of ischemia going on. Maybe he's got septic emboli to the kidney, which you can also see some protein with that as well. Looks like he doesn't have pneumonia. And so EKG, so I don't think I've ever had a fellow tell me about the EKG, just with someone who's coming in with fever, but now I will ask them. So the first degree AV block, so is there some sort of conduction? I don't know if this is new or old. Is there some sort of conduction abnormality? And basically, you think of an abscess. from endocarditis.
So at this point in time, so the team was very confused. So essentially, there was no clear infection, no clear source of infection at this point. The patient had a little bit of fever and some leukocytosis, but otherwise he looked stable. So now the question is, would you treat this patient with empiric antibiotics? And if so, which ones would you use and why?
Okay, so this patient comes in, so he's got a little bit of, so he's got fever, but the thing that strikes me about him is he has so many risk factors for having just bacteremia, because I'm assuming you haven't really told me, the whole story, but I'm assuming he doesn't have a localized source of infection, and we know it's about bacteremia. So, so there's no cough, there's nothing localizing. So I think the hardest thing to think about is that they can just have bacteremia. Because you don't see it, you have to think about it. So, so he's diabetic, he's a tobacco smoker, he's an alcoholic, so he's immunocompromised, he shoots up, so he's immunocompromised, and he has a source, a skin source for bacteremia. And, so if you think about these people, by the way, so diabetics, tobacco smokers, alcoholics should have pneumococcal vaccine, and that's not just because of pneumococcal pneumonia, but also because they can get pneumococcal bacteremia. I don't know if he's HIV infected, because we haven't tested him yet, so that's something obviously that we would want to do. So if I see someone like this, even though, he doesn't have sepsis per se, so, he's got a little bit of fever, he's not tachycardic, and I think that's why you gave it to me like that, so he's not septic. But I think it's probably the better part of valor to start antibiotics on him because he has so many risk factors and he's, in theory, immunocompromised. So what antibiotic would I use? So, I definitely would give him gram-positive coverage because we know he's at risk to have Staph Aureus infection and we know he's at risk to have pneumococcal infection. So, so in someone like this, I'm definitely going to give him Vanco because we know that about half of the isolates that we have here are MRSA. Now, the question of gram-negative coverage is a little bit interesting. I don't think we have any risk factors. We don't know if he's been hospitalized or on antibiotics recently, so I don't know that we have risk factors for Pseudomonas. But I think I probably would give him some gram-negative coverage, although I do have to say I'm biased because I'm sitting up here. So, but I think that as long as I'm giving him gram-positive, I probably would give him gram-negative coverage and then pull back when I know what's going on. So I probably would give Vanco and ceftriaxone.
Okay, that's a great question. So this is something that we struggle all the time. So
Yeah.
we try to sort of like balance stewardship with trying to make sure that we don't risk like overwhelming infection afterwards in these patients.
Right, and that's what it drives us crazy too. Just so you know, because I have to sit with Andres and and explain to him why I'm using cefepime, and so do the fellows. So it's not easy sometimes because sometimes you just have this gestalt and you can't, you really are being pushed for why you're using pseudomonal coverage.
Okay, so the patient actually received vancomycin and cefepime in the ER. However, the admitting team continued vancomycin and then started ceftriaxone instead of cefepime. After 24 hours in the hospital, 2 out of 3 blood cultures are growing gram-positive cocci in clusters. So the question is, what should we do at this stage if we see this positive blood culture? And should we repeat the blood cultures? And if so, when and how often? And should I be consulted at this time?
Okay, so gram-positive cocci in clusters in a patient like this. So obviously you're thinking it's Staph Aureus, and that would be, the worst thing that it could be. So you're covering him for MRSA. So you continue the vancomycin. I might wait a day or two just to make sure there's no gram-negative that's coming out of there. One thing I want to say is that IV drug users, there were these pockets of Pseudomonas bacteremia from, I don't know if anybody's ever heard of that, but it was associated with specific drugs, which are like T's and blues, triple-enamine, and something else. But those, we haven't seen that more recently. That was way in the past, if anybody's heard of that. Anyway, so gram-positive cocci in clusters. So we think Staph Aureus, and so we want to cover for MRSA until we get the result back. So we're going to continue the vancomycin, and at that time, or maybe in a day, we'll stop the ceftriaxone, assuming the blood cultures are negative after 48 hours. So the thing is, though, we don't know that it's Staph aureus. It could end up being a coag-negative staph, and he doesn't really have that many risk factors, or any that I can think of, for having a coag-negative staph, true bacteremia. So I think at this point, even though he's on antibiotics, so I would redraw blood cultures for a couple reasons. Well, you didn't tell me. Did you tell me what day it is that this has come up positive?
This is on the second day of admission, so
Okay.
more than 24 hours.
Okay.
But less than 48.
All right. So so hopefully, there's always a possibility he may have cleared his bacteremia by then. So I would repeat his blood cultures, even if it does turn out to be Staph aureus, because you have to make sure that the blood culture is cleared, that you've cleared the bacteremia with Staph aureus, because it's a virulent organism, and as we know, it goes to different parts of the body, and it's difficult to clear. What am I missing in terms?
The other was like, should we consult ID?
Oh, okay. So you should consult ID. I don't know if you want to. My fellows? What should they? So let me just tell you what's clear. So what's clear is that if you have Staph aureus bacteremia, there have been several studies now which have shown that that patients do better with an ID consult. I think probably every subspecialty has done these studies, for their own subspecialty. So with Staph aureus bacteremia, inpatient, the mortality when they're inpatients decreases if you have an ID consult. Length of stay decreases, and the percentage of patients that come back with bacteremia decreases with an ID consult. Even when they compare ID consults, like a regular ID consult, with a curbside consult, ID consults in person have been shown to be better. So definitely with Staph aureus bacteremia, you should get an ID consult. Now, I guess with 2 out of 3 blood cultures being positive, and the patient, even if the patient ends up having a different bacteria like a coag-negative staph, you probably would want to call ID just to help you determine that it's a contaminant. You guys agree? Yes. Okay. So the fellows, I don't know, one fellow is like agreeing, and one's not quite so sure. Yeah, okay. So for West, if it's on the weekend, I don't know.
So I'm sorry. So we have the blessing from Dr. Rosenberg. So now we're calling consults on these patients.
What that about? I don't know that there have been those studies. There aren't a lot of quality inpatient quality indicators for ID like there are for other subspecialties, because other subspecialties have procedures, so they can look at quality indicators. But for ID, like the one quality indicator that we have is Staph aureus bacteremia, because there are a set of things that you have to do, like get follow-up blood cultures, find your source, make sure the patient's doing well. So those have been looked at, for individuals, individual ID doctors as being something we look at to make sure that they're good doctors, as opposed to like a gastroenterologist and, how many at their percentage of adenomas or whatever in GI that they have. So I'm only aware of it for Staph aureus. It may be for others, but I haven't seen that literature. Okay. Come to the microphone.
Come to the mic so people can hear you.
No, we want those studies though, because we want the studies because we want to prove those things, because people might not believe you. People might think that you could just call you, right? I'm talking to Joe Sabia, who's one of our fellows. So yes, so people might just call you on the phone and say, well, that's just good enough, but it's been shown that it's not just good enough. But what Joe is saying is that if you have a question, you call. End of story.
Okay, so the team for this that was taking care of this patient decided to continue antibiotic therapy with vancomycin. They reassessed the patient and do a full physical exam again, trying to find a source, and they couldn't find any sources at that point. So they decided to do a TTE, and the TTE came back as normal. The patient remained stable for the next 24 hours, and on the 3rd day of admission, blood culture speciation results as MSSA. So the next question is, what should be done in regards to antibiotic therapy for this patient? And if for the workup, for trying to find a source of bacteremia was negative, what should be the duration of antibiotic therapy? And another follow-up of that is that are oral antibiotics acceptable?
Oral antibiotics is excellent. What was the first part of the question?
So I said that what should be done in regards to antibiotic
Okay,
therapy?
okay.
So the patient is still on vancomycin, so what should be
Okay.
done in regards to that? And then if hypothetically we say that all the workup was negative for sources, what do we do in terms of duration?
Okay. So, one of those quality indicators I was talking about for MSSA is that if it's MSSA, you should not use vancomycin. You should use a beta-lactam. So what's been shown to be equivalent are a semi-synthetic penicillin, so nafcillin or oxacillin. Here we have nafcillin, or cefazolin, meaning Ancef. So first generation cephalosporin. So it's your choice. I used to use nafcillin because patients could go home with a continuous pump and they just walk around with it and it would shoot out nafcillin every 4 hours. But I've seen now 2 cases of what I think is acute interstitial nephritis recently with nafcillin, so I've decided I don't like it anymore and I like cefazolin better. So that's my personal choice. You can use what you want. So how long should you treat for? So you have to decide whether it's complicated Staph Aureus bacteremia or uncomplicated Staph Aureus bacteremia. And you really have to make sure it's uncomplicated because the treatment there is 2 weeks as opposed to about 6 weeks for complicated bacteremia or endocarditis. So, so for it to be uncomplicated, so the patient has to have defervesced, so fever and white count have to have gone away by about 3 days. You have to show that you've cleared the bacteremia within 72 hours. So that's why it's important when we tell you that you should get follow-up blood cultures every 24 to 48 hours. That's why we're telling you that. And remember, it takes a couple of days. You're always behind. I mean, now we're not as behind since we have better blood culture systems, but generally we're behind in terms of knowing what the blood culture is going to be, because if on antibiotics it can take longer for a blood culture to come out positive. I didn't say that before. So there's that. So clearance of the bacteremia, they have to defervesce. If there's a source, it has to be removed. So like, for example, if you have a skin abscess, then you have to get rid of the skin abscess. They have to be on a beta-lactam if it's MSSA, and an echo has to be done, and the echo has to be negative. And that's like sort of a whole nother can of worms, whether you have to do a TEE or whether you can just go by a TTE. So what the literature says is that there are several parameters where you don't have to get a TEE. But the thing is, those are to come upon those, it's very rare. So it has to be a nosocomial bacteremia, which hopefully we don't see a lot of. We do see some, but not a lot. And it has to be a patient that's not a hemodialysis patient. And then the rest of what I just said would be the same. So they defervesce very quickly. They've cleared their bacteremia within 72 hours. And those people would not need a TEE. But those are not the people we see. We see the patient that you presented. And this patient, you really have to be very sure that it's not endocarditis to change it to a 2-week therapy from a 4-week therapy. So in a patient like this, if the TTE is negative, I'd probably get a TEE.
Yeah. We said that for most of the patients that we receive from the community, a TEE is indicated.
Well, for most patients, some patients I don't do it, but I can't tell you who that is unless I've seen it. And also this patient, let's not forget, he has a first-degree AV block, which I don't know if it's new or not. So, I would be more concerned.
Absolutely, yeah. So my next question was actually in regards to TEE, but I think you answered that pretty much already. So, and that question had a little bit of follow-up. So it should be a reflex for every patient with staph bacteremia to do a TEE if a TTE is negative. And then are there any patients in whom the pretest probability is so low that they don't need a TEE? If you can just clarify that again.
Yeah, so what the literature says is that, again, you have to have certain parameters to not do a TEE. Those are guidelines, but I think that just in reality, not every patient is getting a TEE, and not just because not everyone can there are the people that can't tolerate it, that you're concerned that, they might perforate or whatever. I think that there are people who, that you have a source, you've gotten rid of the source, they've defervesced very quickly, like a line, kind of thing, and I don't think every patient needs a TE, just in reality. And there are some studies to back that up.
So in regards to other tests, particularly what I'm referring here is to imaging tests to find out a possible source, such as a discitis or an epidural abscess. Should all patients with with the staph bacteremia get this type of test, or it depends on what the physical exam shows or the symptoms that the patient have?
Right. So in patients with Staph aureus bacteremia, it's very important to do a good physical and to get a good history. So you really have to go from head to toe and ask them if they have any back pain, because obviously one of the big places it can go is to the spine, and so they can get discitis, osteomyelitis, epidural abscess. So you're going to ask them if they have back pain. You're going to ask them if, and also obviously on physical exam, and you have to really pound on their spine. Okay. You want to know if they have any septic emboli, whether they've infarcted their spleen, for example. So left lower quadrant pain or left upper quadrant pain. Flank pain for renal infarction or psoas abscess. Whether they have septic pulmonary emboli or not. And then if they have any foreign bodies, that's obviously very important and the most important thing. So if they have, a joint replacement. So, it's very important to evaluate that joint. But you can do it all clinically. So it's not necessary to do a bunch of exams looking for these things. So just, they should have pain at the site. So they should come in with back pain, and they do, if they have something on their back. But what's really important when you're following these people with persistent bacteremia is every day you have to go through the same rigmarole, because believe it or not, we had a patient several years ago who had Staph aureus bacteremia that didn't clear, and nobody knew for days that the patient couldn't move her legs. And she became paraplegic because she had an epidural abscess, and she didn't tell anyone she couldn't move her legs, and nobody knew. So it's very important that you do a good physical exam every day.
Absolutely. Thank you very much. My greatest shame as a resident was we had a patient that with fever of unknown origin admitted to the hospital, and we were trying to get everybody on board, trying to figure out what was going on with the patient, and eventually one of these PM polymorphonuclear tag tests was ordered, and it actually lighted up in the bottom. And when we examined the patient, had a big abscess in there, no one saw it. So that's my greatest shame as a resident for not doing a correct physical exam.
Right, so the way we stated is you could have done better, right? We all have those cases. I actually have one of when I was a resident of a diabetic, which is interesting from this, but a diabetic who came into the emergency room, and in those days we ran the emergency room, and it was here at St. Luke's. And we sent the patient out, and the patient came back the next day septic with pneumococcal bacteremia. Yeah, so that's my case. Yeah.
Thank you for sharing that. So next question is, what are site? I mean, you already mentioned the possibility of the back and the splenic abscess. So this question was about what are usual sites for seeding of Staph bacteremia, Staph Aureus. I think that is already answered.
Well, let me just say, though, that Staph aureus is pretty virulent, so it can go anywhere, but it tends to go to the places of least resistance. So that's why it goes to the spine also, because everybody has a little bit of DJD, degenerative joint disease. So it does tend to go where there's least resistance.
Okay. So our patient is diagnosed with infectious endocarditis after a TEE. And it actually, this TE also confirmed the presence of an abscess in the AV valve, and that's probably the reason he had a first-degree AV block. So thoracic surgery was consulted. The patient underwent surgery and continued antibiotics for 6 weeks. And as far as we know, the patient is cured. So I just wanted to stop here because I know infectious endocarditis is another huge topic, and didn't want to go there. Only to address the bacteremia, the gram-positive bacteremia type of questions. And I would just like to give the residents the opportunity to ask any questions if they have any.
Thank you, Dr. Rosenberg, for that talk. I had 2 questions. Number one, based on the literature which came out last year, which patients would be suitable for treatment with oral antibiotics? Similarly, if this patient would be a candidate for oral antibiotics, and when would you make the switch? And the second question is, some hospitals have been moving away from routine isolation for MRSA. Which patients would you want to be on precautions for contact precautions for MRSA, and which should not or which do not need to be on contact isolation?
Okay, thank you for those questions. So the study that you're talking about was in the New England Journal last January, I believe, about switching, and it was not done in the United States, and it was about switching it was for left-sided endocarditis, but I don't think it included MRSA. I think it was just MSSA. And it was switching to oral antibiotics after a certain amount of IV, which I believe was about 10 days or so. So it's an interesting study, and but I don't think that at this point that people are doing it here in the United States. And there was actually, our ID Society just put out a questionnaire to people about whether they use oral antibiotics for certain infections, because now there's more and more literature coming out regarding, decreased number of days of antibiotics and using oral antibiotics. Now for some gram-negative infections, we only give 7 days for bacteremia, and we used to give 10 to 14, that kind of thing. So there's more and more literature coming out, but I think there needs to be more literature before we start doing something like this. And actually in the 1980s, a study came out about right-sided endocarditis using, if it was susceptible for Staph Aureus, using Cipro and Cipro and rifampin, for endocarditis. And it never really caught on, is the bottom line. So I think just in general, it's not something I'm willing to do yet. I don't think there's enough information yet. But, it's interesting. If people, if you have somebody who absolutely has to leave the hospital, you should think about treating them with oral antibiotics if they can't go home on IV. There are certain situations. I won't go down that road, but not yet for now. So contact precautions. So there's a lot of information on this now. It sort of goes full swing. I mean, here we didn't have precautions, and then it became for MRSA, and then we did, and we don't. We still seem to have the same number of MRSA isolates that we had, whether we have it or not. And just in the literature, there's more and more literature about decreasing precautions for all these patients. Does it really help? Do we not go into the rooms because we don't want to put on the protective gear and that kind of thing? So there is a whole separate infection control department. So so I'm not going to answer. So I don't know. I don't think anybody's willing to stop precautions yet, and we're a system as well now, so it's not necessarily our decision. But, it is something that's being actively investigated in the ID literature.
Any questions out west?
Thank you, Dr. Rosenberg. I have one more question when it comes to lines and infections. Catheter tip cultures, relevant, not relevant? If relevant, where?
So, just in general, you should not send a catheter tip for culture if there's no reason to. So when you take a catheter out, you throw it away or do whatever you do with it. It is still relevant to send a catheter tip. I mean, there's this whole, all the guidelines, I kind of sort of didn't get into it that much, but all the guidelines are pretty old guidelines. I mean, but you can still send it with blood cultures. You can send it for culture to see what the culture is. There's sort of quantitative cultures, but you can just send it for qualitative cultures just to give you an idea. But you need to do it with blood cultures.
Any other questions? Questions? Thank you very much, Dr. Rosenberg.
Thank you very much. I'm sorry I talked